Thank you for joining. This is the May 29th webinar of the Connecticut Health Policy Project. I'm Ellen Andrews, Executive Director of the Connecticut Health Policy Project. Patient-centered medical homes are sweeping Connecticut and the country, providing very impressive results, improving our complex and fragmented healthcare delivery system. For example, here in Connecticut, shifting our Medicaid program to patient-centered medical homes over the last several years has resulted in greatly improved quality of care across numerous metrics, better access to care with the number of participating providers up 32%, which we're very happy about, and 2% reductions, actual reductions in per person costs of care. There is strong and growing evidence in Connecticut and elsewhere that care provided inside patient-centered medical homes across programs is better quality with better health outcomes, and that people are more satisfied with that care. Patient-centered medical homes are a new way of providing primary preventive care where people are given the tools they need to direct their own care and keep themselves happy and healthy. When a person has a medical problem, they don't have to figure out who to call. They call their medical home. The medical home also keeps up with them, not just making referrals for needed specialty care, but making appointments with the patient and following up on treatment plans. Their medical home reminds them when it's time for preventive care and when screens are due. Care is delivered by a team of providers with different skills and different strengths, and care is available beyond usual business hours. As one nurse manager in a patient-centered medical home in New York told me, all the care swirls around the patient, not the other way around. Certified patient-centered medical homes are reimbursed for this higher level of care and effort in different ways, in different plans and different programs. There are several national accrediting bodies that certify patient-centered medical homes, but most, 4 out of 5, are certified by NCQA's process, the National Committee on Quality Assurance. NCQA is the gold standard in patient-centered medical home recognition. And we are very fortunate today to have 2 experts on patient-centered medical homes from NCQA for this webinar. They'll explain the standards and the process they use to ensure patient-centered medical homes are effective. Tricia Barrett is Vice President of Product Development, and Will Robinson is Manager of Public Policy at NCQA. We're very lucky to have Tricia and Will with us to tell us how they do it. Some housekeeping for the webinar. If you're listening on the phone, remember to input the audio pin that should be visible on your screen if you want to be able to talk and ask questions. We'll be keeping everyone on mute until the speakers are finished, and then we'll have time for questions. To ask a question, you can raise your hand by clicking that button, or you can type your question into the text box on your screen at any point in the webinar. And a video of this webinar will be posted online soon. Thank you, Will and Trish.
Thank you, Ellen. Oh, I'm hearing some people.
This is Mina.
Oh, hi, Mina.
Hey, Mina. Ellen, also joining us on the phone is Mina Harkins. She's an AVP in our
product delivery for recognition program.
Product delivery. She oversees all of the people that do the patient-centered medical home reviews.
Oh, so Ellen and I have talked before.
Yes. Hi, Mina.
Okay, great. Okay, so I'm going to go ahead and get started. Ellen, have I gotten control? There, I think I do. Okay, so thank you for having us today. We're really pleased to have the opportunity to talk with your group in Connecticut. A couple of key points that we intend to make today. The recognition program is really intended to assess whether or not a practice has managed to change the way that they practice in ways consistent with what Ellen described as the kind of goals of the medical home. Having this care coordination and care management, a focus on the patient, helping them to navigate through the fairly confusing healthcare system that we have in this country, provide for advanced levels of access and ability to obtain appointments outside of sort of typical banker's hours and perhaps on weekends. So, but allowing for practices to have the flexibility to identify what are the needs of their particular patient population and make the changes that make the most sense for that population. So rather than saying every practice should be open until 8 o'clock on Wednesday, we say, you know, practices need to have an understanding of what the access needs of their patient population is, and then adjust their access to meet that. And then assuring that patients are really involved and engaged in the conversation about their care in making the decisions about what treatment is appropriate. We've been continuing to evolve this program since we initiated it back in 2002, really was the first version of what is now the patient-centered medical home recognition. So that's a fairly long track record of experience working with practices, understanding what makes for the kinds of changes we're looking for and the kinds of resultant outcomes that we would hope to have from primary care practices, and really tweaking and modifying the program to sort of acknowledge what are the best ways to measure whether or not a practice has in fact made some of the changes that are important in the design of their practice. There is a growing amount of evidence that's indicating the patient-centered medical home model, which is what we evaluate. We look to see, is that model in fact in place in the practice? That model does in fact lead to improved quality and lower costs. You know, more and more evidence is coming out. This is difficult because it's been embraced pretty widely, and so, you know, having good controlled trials and so forth, the kind of studies that researchers would really love to have are not necessarily available, but the kind of evidence like Ellen was describing, the success that Medicaid had in your state in adopting it, and we have many examples from other states, Vermont, North Carolina, Pennsylvania, New York, others that have had success in adopting this model and utilizing an NCQA recognition as a core piece of that model. And then, you know, I think it's fair to say that the work that we've put into putting the program in place, designing the operations, designing the actual requirements, modifying them over time, investing in the research necessary to understand what should the next phases look like. So each time we release a new set of standards, which we've done basically every 3 years since we launched the program, we don't just stop with the release. We continue to gather information after the release from practices as they go through the program, from the researchers that are engaged in evaluations of programs, from other research that we directly get involved in to really understand what needs to come next and begin to evolve and create that new content, test it out, so that when 3 years comes around and we want to release another new version, we've got that. So it's a pretty significant investment of time and energy and effort on the part of NCQA to remain current with the best available evidence across the country. I'm going to not go too fast. So I've already kind of hit on the fact that our goal here is to evaluate that practices have in fact transformed into medical homes. We've been around for a while. We are able to draw from the best available experts around the country. People are more than willing to volunteer their time to NCQA committees, to our input processes and our efforts for research work, talking with practices, etc. So we can really garner all of that attention and interest and draw it into the development of our standards. So very important part of our process is to make sure that we have good experts at the table debating the issues, coming to consensus around what are some core competencies that we should be looking for and how might we go about evaluating in a fair and effective way whether or not those competencies are in place. So our program, when you look at our standards, which we make available free of charge on our website so that anyone can look at them and get a feel for what the expectations are, we try to be very explicit in them. Our whole mantra, our vision here is improved quality through transparency, accountability, and performance measurement, and that we believe that we need to hold ourselves to that. We want to be highly transparent about what the expectations are that we're looking for, exactly what a practice needs to do to achieve that, so that they can really focus on the actual changes that they need to make within their practice. That said, we lay this out in as much detail as possible, but we provide for a tremendous amount of flexibility. I gave the example of practices don't have to adhere to a specific defined definition of access in terms of office hours and so forth to meet our standards. We say the practice needs to have extended hours. They need to have an ability to have for patients to receive access on a same-day basis. But we then say, you determine as a practice what is going to best meet the needs of your patient base, and you design your access, your office hours and so forth to meet those needs. So there's this flexibility built into each of the requirements so that the practice can really make it their own and embrace it with the patients that they are serving. We do have 6 core standards. I've got a slide that's going to go through each of those standards. And then within those, there are items that we call must-pass elements. And I'll hit on what those items are, but they're essentially defining a baseline of expectations. If there aren't at least these particular components in place, we would not want to label the practice a patient-centered medical home. Beyond that, then there's a number of points. So there's 100 points possible to be achieved with the recognition based on all of the standards that are there, and you need to achieve 85 of those 100 points in order to achieve a level 3, which is the highest level of recognition. In all cases, for all levels, you need to achieve all the must-pass elements that I'll hit on in a moment. The practice assesses themselves. So they've got a tool. We have a software tool that they use. They plug in their answers. They kind of go through all the material. They figure out what they've got in place. They can do a gap analysis based on looking at the full array of standards and how they seem to be scoring based on their own assessment of what they've got in place. And then when they're ready to do so, so they believe that they are meeting all the items that they want to meet, then they can submit to us. And when they do that submission to us, they'll have answered all these questions that we ask in the standards, but they would also attach the documentation that supports their answers. And then that's where we come in and begin to do reviews to assess whether or not the material that they've provided really does give evidence of the requirements being in place. I'll try to give some examples of that as I go through the actual standards as well. So here's the standards as I promised. You can see the way we organize our content is we have standards. Those are the numbered items. So patient-centered access is our first standard. And then we have elements. So the items that have letters are called elements. And so patient-centered appointment access is the first of the elements in the standard. When you drill in further into patient-centered appointment access, something that's part of NCQA's secret sauce is we've gotten very good at really figuring out, well, what is it that would qualify a practice as saying they've got patient-centered appointment access? And we break that down into some finer points of, in this case, do they have the ability to provide for same-day appointments? Do they have the ability to provide access that goes beyond typical 9 to 5 when most people are at work and have difficulty being seen? Are they monitoring their accessibility to make sure that patients are getting in when they need to and adjusting their approaches to access when they need to do so? Do they monitor no-show rates to see that they don't have issues of people, making appointments, clogging up the system, but then not showing up, and maybe there's something they should do about that? So a number of scorable features to say, yes, this practice has this conceptual thing that we have called patient-centered appointment access as evidenced by all of these different activities and reports that they're able to produce. An important thing to note is that some will say, well, it's very process-based. Yes, there's a fair amount of this that is about a practice putting in place the processes to assure that things are done consistently. Because certainly something that has been true about healthcare is that it had been practiced much as an art, and kind of resistant to the idea of standardization. But in fact, standardization can be a beautiful thing for then layering in the artistic pieces that are necessary to have good individual relationships. But that standardization just provides for an ability for the practice to day in, day out, deliver on the promise that they think that they want to be delivering on. And we have, on so many occasions, had conversations with practices, particularly with practice leaders, the physician in charge perhaps, say, I thought that we were doing all these things, but then, I really took the time to talk with the front, desk person and realized, oh yeah, well, we sort of do it, but only when Sally Joe is in the office, and sometimes she's out sick or whatever, and so there's not this consistency, and it's really very important to have that consistency in order to have a predictable delivery of high quality care and service. So I've dwelled a little bit on the sort of structure here, but you can see as you've been soaking in this slide, we have these 6 standards, patient-centered access being the first of them with a lot of emphasis on it. You can see the numbers that are in parentheses are the number of points associated with each of the elements that are listed. The items that have the star and the bold are ones that are designated as must-pass. So what that means is that any patient-centered medical home designated by NCQA must at least have a 50% score on the elements listed here. And if you look at our actual standards, the details, you can see exactly how they'll come to that 50% score. But patient-centered appointment access, it's going to include that they must have a way of getting people in for same-day appointments when that's needed for the patient, and that they can have their triage, they can have mechanisms by which they make the decision about which individuals get priority for those slots, but there should be availability of same-day appointments on a regular basis. The next element, or the next standard, team-based care, something that we've learned through the iterations of the program is how important the real embrace of this team-based methodology or construct is for a practice in order to achieve and sustain the medical home concepts. So we have heard from practices where perhaps the lead clinician, the physician or the nurse practitioner in charge has kind of taken everything on their shoulders, and they just do more, and they just work harder, and they stay longer, and they get these things done. And you can imagine that that's not likely to be very sustainable if they don't also embrace the idea of their team, that the team needs to be a well-functioning group, that everybody in the practice is part of that team, and they each have a role to play in making sure that all of these types of services that we're looking for out of primary care are being delivered in a consistent way. And so as a result of that learning over time, we have now made this a must-pass requirement. So team-based care has always, these elements that you see listed there have always been part of the standards, but they were part of the patient-centered access of that sort of category, and they didn't have their own must-pass element. So now we've made the practice team a must-pass element, and within that, the practice team needs to have a mechanism for regularly meeting to plan for patients that are coming into the office. Being proactive about the fact that an individual is coming in that day or that week, and they talk in a case conference around that patient to make sure that all the things that are necessary for giving good care to that person are lined up, and any additional supports, they check and, oh, we had referred this person to cardiology. We haven't seen the report yet for that. Let's make sure that we get that in place. Or, oh, they really should have this lab test done before they come in. Let's order that and have them get that done before the appointment time, so forth. So really planning for that visit. Population health management, this is a shift in thinking for many practices of doing the best that they can for the people that walk in the door, to thinking about owning the relationship with a group of patients over a long period of time, and making sure that those patients that aren't showing up at the door for care are getting the care and service that they do need. So using data, using their information systems to be able to identify the individuals with diabetes that haven't had their HbA1c tested recently. They're people with, who are women who are over 50 and haven't had a mammogram recently. All the individuals who've had are on a particular medication and now there's been a recall of that medication. So an ability to really look in their data and use it to really manage the total population health. Care management and support, critically important. We want to make sure that the practice focuses their more intensive resources on the individuals who have the highest needs. So we have made some changes here in this particular standard regarding how practices should identify the individuals for their care management support. In the past, we've said you should identify based on specific chronic conditions, and they choose which chronic conditions. We also had an expectation for identifying high-risk patients. We've now said, we really want you to focus in on this idea of high-risk individuals across a spectrum of needs. It includes behavioral health needs, physical chronic care needs, their sort of social dynamic and potential needs that relate to their social circumstances. So their income or family situation, anything that might make them vulnerable as a result, we think might be an appropriate way of identifying an individual who could benefit from the extra resources involved in a true care coordination, care management function that a practice would be expected to have. And then we expect them to, in fact, deliver on that on a routine basis. And so another place where we don't just expect them to have a policy or a process in place, they need to be monitoring all of these things. In the case of care management, we have them actually do a chart review and confirm that the kinds of things that we're looking for in a care plan for the individuals who could benefit from case management or care management are in fact in place, that they can find evidence of it in the medical record showing that they've given the patient a care plan and guidance related to their self-care needs.
I'll also say I thought one of the more important things that we added this year in the care planning section is, and I'm not sure if this is 2011, so Tricia, let me know, but I know in 2014 there was a requirement around including patient goals in the care planning process. Mm-hmm. We think that's really critical. A lot of the care planning or a lot of care plans are just sort of automatically produced out of EHR systems. It's, okay, I have diabetes, then I need to hit this HbA1c level. What we think is a much better strategy for helping patients get better is talking with them about really what they want. Okay, you want to go to church. That means you're going to have to get back on your feet and walk there. That also means that we're probably going to have to manage your diabetes. It's a motivational interviewing tactic that I think is really important to the patient-centered goals of this whole model. Mm-hmm.
And while that expectation was there in the 2011, I would say it's far more clearly drawn out in the 2014 standards, where we're specifically looking for them to have documented what the patient's goals are as part of their care plan. The care coordination and care transitions is where we expect the practice as the medical home to serve as that hub of need for their patients, so that if there's a lab test, if there's a specialist referral, if there's acute care needs that the patient ends up with, that the practice kind of has their back and is in a position of sort of coordinating all of that care and service and making sure that the information is coming back to primary care to help that patient really dissect it and figure out what's going to be the best course of care for them based on it. Will also help to reduce duplication of effort and services, because when you order tests and they get done and nobody ever sees the results, eventually it's going to get ordered again, and you could have a lot of safety issues certainly in the meantime, but also wasted resources and time and effort on the part of the patient that has to go through that testing repeatedly. Finally, of course, we couldn't have a program that doesn't include an expectation for a real emphasis on quality improvement, performance measurement, and ongoing actions to improve. An enhancement that we made in this, the 2014 version of the standards, was to specifically call out each part of the three-part aim. And for those that aren't familiar, it's the improving clinical quality, improving patient experience, and improving the cost experience of patients. So that's our version, at least, of the triple aim, and we wanted to explicitly require that practices have a strategy and a plan for measuring each, sort of measuring a set of indicators in each of those categories, and then acting to improve on each one of them, having a focus on improving patient experience as well as clinical quality. Certainly a tendency for practices to really focus in on that clinical piece as the thing that they're more comfortable with. So we're sort of pushing them beyond that to be focused on all three parts. You could see, you probably can't actually see it, but meaningful use is embedded within all these standards. We've tried to align with the expectations that the federal programs have to make sure that practices that are doing meaningful use get credit for it, but at the same time, if they're not in a position to benefit from the meaningful use program, that they at least have the functionalities that we think are critical to being a medical home, and they could do so through more manual means or through piecemeal systems rather than one single certified electronic health record. So a good synergistic relationship between the two. So I think I've hit on all the areas that were really key changes to the recognition program from 2011 to 2014. I do want to just make note of the further integration of behavioral health. We had begun the expectation to, for primary care, to at least screen for depression, screen for some alcohol or other substance use issues, and to have protocols associated with individuals identified with behavioral health concerns. We've called that out a little bit more explicitly, have a little higher expectations around it, and also in the case of the referral management, making sure that the practice has a defined approach to handling behavioral health needs for patients. So there's a place within the standards where practices need to talk to their patients about what their hours of operation are and how they're going to work with the patient to really assure that they get this high-quality, patient-centered care. Among the things they need to explain is what they are doing about behavioral health. Does the practice have behavioral health expertise on site? If not, do they have a specific relationship with behavioral health providers out in the community to help ease the transition from a patient from a diagnosis that might occur in primary care to more specialized treatment that might be required? So just explaining what their process is and who they've got relationships with, and then explicitly in the referral tracking standard, having relationships established with specialists in behavioral health to help, again, with that easing of transition from primary care to behavioral health care. See if my things will advise. Okay, here you just can see the list of individuals who were served on our latest advisory committee. In addition to this terrific group that we have our clinical programs committee that this advisory committee sent their recommendations up to. And the clinical programs committee is a standing body at NCQA that reports up and makes recommendations to our board, who then makes approvals. But that group includes another who's who of healthcare quality in this country, primarily physicians and other clinicians, nurse practitioners. We've got people with all types of expertise, individuals that engage with, that are medical directors in health plans, as well as leaders in large group practices or health system type entities, as well as small practice representatives. So Carol Greenlee, who was on our advisory committee, is also on our she wasn't on this advisory committee. I'm sorry. She was on our specialty practice advisory committee. But she's just a private endocrinologist, single doc practice in rural Colorado. So we have this gamut of individuals that really engage with us and help us understand what the world looks like out there.
And I did also want to say that there's there may be a perception that the committee helps us with high-level strategy. I think the reality is that we get in the weeds, very much in the weeds, at these committee meetings, and seeking their input on everything from the language that's used in the standards, elements, and factors to how the scoring is done. So they are very much, I don't even really, I mean, they're almost like support or technical assistance as in more of the true sense of the word, rather than a committee in the way that a lot of other people sort of view committees. So.
Yep. A lot of detail discussed.
Yes.
So this just gives you, this next slide, the growth trajectory that we've seen with this program. The true patient-centered medical home version, I mentioned that there was an earlier iteration that did look at practice design and so forth, but the medical home concept really came into vogue, I guess, in 2008, and that's when we started counting these particular recognitions. So you can see our recognition is of the practice site, and that's a single geographic location of a group of providers working together. So that the site numbers are, how many practices have been recognized, and then we acknowledge the clinicians that have their own panel of patients within each of those sites, and so that's what that larger number is. So we've got, about basically 35,000 clinicians, or actually, I'm sorry, as of April 31st, you can see we've got almost 37,000 clinicians recognized in 7,300 sites around the country. We have recognized practices in every state in the country at this point, and you can see 205 practices recognized in Connecticut at this point. Important point, something that people get concerned about is, well, can all my practices do this? Yeah, technically all the practices can do this. We see practices of varying sizes, varying levels of sophistication in terms of their technologies, varying patient bases, so highly diverse populations, very low income, rural, urban, just the gamut of practice types and the patient bases that they have are able to, if focused on the right things, come through and be recognized within the NCQA recognition process.
So I can address this slide. We wanted to show how sort of widely used the program is by private and public payers across the states. As you can see, Connecticut is filled in there because of the Medicaid program that Ellen talked about earlier. But there's a wide variety of multi-payer initiatives, sort of down to individual plans that write in their contracts incentives for practices to be PCMH recognized. I'll also note that at the federal level, the Centers for Medicare and Medicaid Services and the Hill Congress have indicated interest in linking patient-centered medical home recognition to the ability of practices to bill complex care management fees for non-face-to-face care management services. That was included in last year's, the proposal was included in the 2014 CMS Medicare Physician Fee Schedule rule, and it was also part of the Doc Fix bill. I can figure out the bill number. I got to rack my brain to remember it, but I can share that with Ellen if people are interested. And so it's one of the few things that the administration and Congress has actually agreed on. But yeah, we were very pleased, and we're hoping that in the rule, the 2015 CMS Physician Fee Schedule rule, that we'll see more progress on that front. I wanted to show a little bit of the breakout in the 795 clinicians that are recognized in Connecticut in those 205 practices. Most of them are level 3. We love to see that high density of level 3 practices. Internally, we're also doing a lot of reaching out right now to the practices that are recognized under the 2008 standards. Many of those practices came in on the end of the life cycle of that program, and so their 3-year recognition is expiring soon. We're undergoing a big effort to encourage them to come through under the 2011 standards, which was really a much bigger sort of quality jump compared to the 2014 standards, where we made more, not necessarily cosmetic changes, but definitely more tweaks here and there as compared to the 2011 and 2008 standards, where there were more significant changes. So we think there's benefits for both patients and practices to come back through either the 2011 and they're actually able to come through the 2014 standards now. As Tricia spoke about earlier, there's a lot of evidence around why the patient-centered medical home model is working, improving quality, lowering costs, improving provider and patient satisfaction. I'm not going to talk about each one of these studies individually. Actually, if Ellen wants to set up the slides after this, these are actually live links, so you can go in and click in and read the study for yourself. I will mention the RTI study, which I think is a really good one. That what they did is they took a little over 300 practices that were patient-centered medical homes that were not, and that were not. So there's like 300 practices that are medical homes, 300 practices that are not, and looked at the, and they had similar patient populations, and looked at the total per member per month spend for Medicare fee-for-service, and found that PCMH recognition was associated with significantly lower costs and a high, what they call COC, or continuity of care index. I think that's the term, which, in my understanding, and Tricia, correct me if I'm wrong, but in my understanding, it's really sort of a measure of patient stickiness. It's a look at the how strong is the relationship between the primary care provider and the patient. There's all this research that shows that patients with long-standing, strong relationships with a primary care provider that's a usual source of care can, they have lower costs, lower ED use, and better health. And so this RTI study, we were really happy to see that patient-centered medical homes have that stronger relationship. I did want to say quickly that there's, I think, a view that from some stakeholders that sort of NCQA's program comes as it is. There's not a lot of room for augmenting or tweaking or changing to meet state needs. I think that our partnerships with states demonstrates that that's not necessarily the case. There's a number of states like Vermont, New York, Maine, Missouri, and others that have tweaked the program in ways in partnership with us to sort of meet their goals. One of the key ways that they can do that is adding a must-pass element. So Tricia talked about those elements that we consider foundational to being a patient-centered medical home. States like Vermont and others have added, saying you have to meet this element to receive an incentive payment. I assume it's sort of built into their their incentive payment contracts. But yeah, that's a really good way of saying we are really interested in this standard. NCQA doesn't make it a requirement, but we want you to meet it, and you have to meet it to receive a payment. There's also, I think, another way that states are doing this is requiring specific clinical quality measures, patient experience measures, resource use and care coordination measures to be reported by the state, and they create the infrastructure around the practice that gives them the capability to report that, and then they do the data analysis and they do the data analysis to be able to say, okay, here's how you fit, and the word I was looking for is benchmarking, benchmarking against the other practices to be able to say, here's how you fit in the scheme, here's what you can do to improve, and it really focuses the practice's quality improvement efforts at the same time as giving them an easy vehicle to meet some of our standards or some of our elements in Standard 6. I'll also say that as we are in a very much a learning mode right now in looking at sort of the next generation of the model, we sort of always are. I think now is a real critical time for this, but we are definitely open to discussing additional program modifications with the states. We are keeping a very open mind about critiques of the program and ways that we can improve both the evaluation and the standards to ensure that we are reflecting the best evidence base and best practice in primary care delivery. Tricia talked about this earlier. I'll just reiterate that what we do is not easy. It takes a lot of hard work. Not only we have 35 FTEs that do the PCMH reviews, but we also have Tricia's staff, which is continually tapped as these products roll out to do re-reviews and reinterpretations of sort of what we mean by the standards. It's critical to provide practices with the clarity needed to understand what our expectations are for them. And that's a really key part of our program operations and oversight in moving the program into the future.
And while it indicates we have staff on site that do reviews, we also have external reviewers, and then keep making sure that everyone who's engaged with it has the same common understanding of the expectations is a challenge. So what's next with NCQA's recognition? We've just released the 2014 version. We are in a transition period where practices can choose to submit either 2011 or 2014 based on where they kind of are and what they feel most ready for. We are working internally on process improvements, I would call them, I guess, making sure that we're really looking at what's necessary to look at, that we're validating the right information, but perhaps easing off on some other documentation requirements that might not be adding as much value. So we're taking a very strong look at all the information that we've gathered over the 6-8 years, whatever, that we've been working on these kinds of reviews, and which aspects of the standards practices have the most difficulty with, making sure that we're focusing our education and our training and our communications around those areas to help them really understand the expectation. We'd really love for recognition to just come out of being a transformed patient-centered medical home. Certainly there are steps involved in the validation of what's going on within the practice to have that good, strong, third-party, rigorous review conducted, but to the extent that everything that they have to do to get recognized is something that they really need to do for good patient care, that's our ideal world, and so that's what we're working on in terms of some process improvements at NCQA. We also are working on a benchmarking project where we're looking to work with a number of technology vendors, either electronic health record vendors or data aggregators, so all payer claims databases or health information exchanges, sources of kind of rich electronically available information about care delivered in these practices, and seeing are there ways that we could use that clinical information. And then separately, we've got a project working with the PCMH version of the CAPS instrument to see if we could streamline it to a shorter instrument that would be perhaps more readily adopted in practices, and use then, what we'd like to do is be able to use information on this actual standardized performance measurement to supplement and perhaps replace some of our standards. So, a perfect situation would be, for example, the patient experience with access is so outstanding that it's no longer necessary for us to review the details of exactly how the practice has put in place the advanced levels of access within the practice, because patients are just pleased and there's no need for it. So that's kind of what's happening next within NCQA and the patient-centered medical home. I think I'm getting some feedback here. So
I'm sorry, it's mine. I just joined again in case there was Anything I can
Oh,
help
okay,
with?
great.
Thanks,
Great.
Lana.
So you can
Well,
go
you're
on-
just in time
mute.
for questions.
I think we're just hitting that point. So perhaps, Ellen, have you taken control back?
Yes, I have.
Okay.
And there we go, questions. I'm going to actually, I see that Alta has her hand up, and I'm not seeing anyone else. So if anyone wants to put in some questions, you can write them into the pane, or you can just raise your hand. But I'm going to take a prerogative to ask the first question. This was really impressive, and every time I think I've got a beat on NCQA, every time I hear it, I learn something more. And the thing I was really struck with is that it's, like you said, the secret sauce. It's like whatever you're doing is meaningful, because in Connecticut, we're seeing the benefits. Care is better inside patient medical homes than outside. And we've also heard from providers who've gone through it about the value of it. My question is, Connecticut is in various settings thinking about creating a new Connecticut specific standard rather than using NCQA. And that has worried advocates on a lot of levels. Among our concerns are, wasting time, delays. We're hearing that providers are saying, well, I'm not going to do this because, the state's going to do something different. So why don't we wait a few years, which is just delaying all those benefits getting to people. Another real concern is, we have new elections here, which is democracy, and it's a wonderful thing. But that means that the political winds change. So if we do something here in Connecticut and a new administration comes in, they could change it in all sorts of ways. Whereas NCQA doesn't care who's the governor here in Connecticut. So maybe you could talk about, if Connecticut did do our own new specific one, how would that work? How long would it take? How much money it would take, and how much staff it would take to develop it? And then I have another question, actually.
Yeah, so I'll talk at a high level, Ellen. It's tough to predict, depending on, a lot of the answers to those questions depend on the approach that the state would take. So I think it's tough to say specifically how much it would cost. I know that we've invested a significant amount of money in bringing our program to where it is today. So if it takes a lot of time, effort, sweat equity to bring these programs to a position where they are efficient, effective, and clear, and really help practices transform. So I'll also say that we share, I think, a number of the advocates' concerns about states developing their own models. We're worried about the fact that we think state resources could really be better spent in other areas, like supporting community care teams, really actually just paying primary care providers more money. We know they're underpaid. We think they deserve a raise, and whether that's through some sort of incentive or pay for performance program, we think instead of sort of recreating a evaluation program, the money would be better spent on those activities. The other activity, which I think is actually most critical, is the infrastructure that's needed to do the quality measurement, benchmarking, and analysis that can really help practices transform. Practices oftentimes don't have the capability and the infrastructure to be able to do that, and I think that a number of states that have done this really well have built the necessary infrastructure and analytics team to be able to collect, analyze, and churn this data in such a way that it's actionable for quality improvement. The last concern that I'll issue is that we're really worried that this is sort of a flavor of the moment, that like you said, if a new administration comes in, or if the state legislature changes and there are different budget priorities, that's just the way that sort of state politics works, and we're really worried that is the same level of investment and commitment to the model going to be there in 5 or 10 years? I mean, we will be here certainly, but we're worried that the state commitment could change. So I hope that answers your question. I think it's hard to speak to the specifics because there are still a lot of unanswered questions about exactly which direction the state is going.
That, the development of the actual expectations and maintenance of that, and providing the support to practices, the education and so forth that we deliver is kind of a fixed cost. Doesn't matter how many practices you have. So that $10 million figure that you saw in terms of our costs over the life of this program for its development, that's not the delivery of it. That's not the staff to administer it daily, but just to make sure that we are maintaining the right requirements. That's something that'll be repeated in each state that wants to really invest, if they want to do it right and do it well.
I mean, luckily we've already done a lot of the legwork. We've put so much of our time and effort into developing the standards. There's we've seen other states sort of honestly take a lot of what we've done directly, which is their prerogative, but we share your concerns.
We have another question. We have a couple here, actually, so I'll move through them. How do you address language and cultural issues? Do you go beyond the language line? And I think this fits with another question, is about how you talk about working with states who ask for more options, or to make options that you have optional, like the class standards for cultural competence, to make them required. I also saw measuring patient experience of care, and another thing that's come up in Connecticut is oral health. Maybe you could talk about how you work with states to make sure that they have things like language and cultural issues covered.
So I can talk about, first of all, we do have a standard that expects practices to understand the diversity of the population that they're serving. So they're expected to look for and to record information about race, ethnicity, and language needs, so that they have both that cultural sense and the direct language needs. The expectations then go on to say you need to provide for language interpretation. So language line might be one of those things, but also for languages that exceed 5% of their population, they need to have printed materials in those languages. We also look for them to take their performance information and stratify it by sort of population type. So they can pick which diversity categories they want to look at, but for example, if they have a large African American population, they're likely to say, all right, how do the diabetics who are African American get as good of care as those who are not, and what interventions should they do to address disparities in care that they are able to find based on that kind of assessment. So we want them to collect the information, understand what the needs of the population are, which is certainly a first step to making sure that they're delivering in culturally competent ways, and then look for disparities in care and service that end up happening if they're not doing a good job with it, and take action to improve it. So that's how we address it now.
Great.
What we've done in some states that wanted to make things that we don't require as must-pass, wanted to make them must-pass, we are able to work with the state, provide a data feed of, that says, okay, these are the practices that achieved level 1, 2, or 3, but here's all the detail as well, and that you can apply, or we can apply on our end, additional expectations to it to say, all right, and in addition, they also met, the specific requirements related to class.
Great. Sheldon Todman raised his hand. Sheldon, I unmuted you. You can ask your question.
Sure, thanks. It's great to hear that you're flexible in allowing states to, add on requirements like making some optional criteria must pass. And it is important to hear, because we've heard concerns in Connecticut in justification of a homegrown standard that the NCQA standards are too rigid. So that seems to fully address that. The one specific complaint or concern we've heard is that NCQA practices have to get certified at that time, and it's a lot of work to get there. But then after that, there's no review, for 3 years. in Connecticut, we've really, assuming that's a problem, Connecticut Medicaid has completely solved that, I think, by we learned that they're doing annual monitoring reviews to make sure that there is ongoing compliance with those criteria during that period. So I guess my question is, do you agree that that's an issue? And if it is in some way an issue, what do you think of Connecticut Medicaid's solution to have some additional, survey and monitoring annually in between certification periods?
Yeah, so I certainly think that it can be an issue. I think that it's not necessarily an issue everywhere. I think that where states are heavily engaged with practices in terms of incentives and collaborative learning initiatives or other, the kind of additional supports that Will talked about, many states putting in place, that those practices are engaged and they don't want to backslide. They don't want to have, the gains that they made, slip away, and that can provide that oversight. We've also added in the 2014 version of the standards an expectation for several of the standards to when they come back through, they're going to need to demonstrate that they've continued to do the functions on an ongoing basis. So each year they have been addressing access issues. They've been measuring clinical performance. They've been measuring patient experience, et cetera, and taking action to improve it. So again, that's another thing that would cause practices that are really, have been invested and engaged in the recognition process to not allow things to slip. Also, the population health, they need to do those reminders and recall activities on an annual basis. So many things that we've put in place will assure that the practice is staying in touch with the expectations over the course of the period. We're also looking at whether we want to have, and we don't want to add an additional burden that isn't going to add value. But we are looking at whether there's some kind of attestation, a check-in that should occur between, it's either on an annual basis or perhaps it's just once at a year and a half in, to confirm these are still the physicians at the practice. This is, all these functions are still in place. They're still using, certain systems to support the work, et cetera. I think the idea of an annual audit is perfectly reasonable. I think we're looking at whether that's something that we should put up within our own shop as part of an ongoing compliance assessment. Just knowing that someone might come out and check might be enough to, for those that currently maybe have put things on the shelf, to make sure that they keep dusting it off and regularly looking at it. So
I think we find most providers are really committed to this model, and they are not just doing this just to get the recognition. They're doing it for the right reasons, and particularly the quality measurement programs that surround these medical home initiatives. A lot of the foundations and the standards will support improvements on the quality measures that these pilots do annually. So those are really ongoing activities, and it's really difficult for the practice to come through, meet our standards, drop everything, and go back to the way life was, but still perform really well on annual quality measurement analyses. So I think Tricia makes a really good point.
Thanks. The next question is from, Kevin Galvin and Daniela Giordano basically asked sort of the same question, so I'll read them. To follow up on a prior question and your answer, how long at a minimum do you estimate it would take a state to develop a robust model? Or asked differently, how long, at what staff capacity did it take NCQA initially to develop PCMH? And Kevin's question is, do we have enough time to do it right, to develop, implement, get practices certified, and see any benefits within the SIM 5-year timeframe?
I think that's a really good question. I'm not sure. We started with the first iteration of this program in 2002.
So we had something
built on it for years.
Yeah, we had something really strong in place to then build out to the medical home. It certainly takes several staff people to draw together then the right additional resources from across your state in this case. For us, it was across the country to really drive additional expertise into the conversation to make sure that we were setting up the right rules. You know, the operations. I mean, it's hard to answer that question
without knowing more.
Because we've been in it for so long that our skill set has grown over a very long period of time. Obviously, to put it up new, it wouldn't take, you know, the 8 or 12 years that we've been working on this. But it would take a significant amount of time and energy. And I think, and I think that then as you see the need to evolve it, you know, I think that it'll take most of that 5-year period probably to get to the place where you want it to be.
I think one of the biggest concerns is actually the maintenance, is the continual investment over time to make sure that the program aligns with the best evidence and best practices in primary care delivery. That's what Tricia's shop does here day in and day out. And without that support mechanism for our program, there would be it definitely wouldn't be the program that it is today. It would be a shell of itself, and that piece is such a core component of making it better that without that continual updating, maintenance, and investment, it'd be difficult to do something that I think is really meaningful over time.
Yeah, you're probably being more careful, but it sounds like the answer is no. Quincy Abbott has another question, and that's the last one I have. If anybody else has a question, put it in or raise your hand. In Connecticut, the Dual Eligibles Grant, we have a health neighborhood grant for a 5 pilots for to build health neighborhoods for people eligible for both Medicare and Medicaid. Integrates long-term services and supports with medical services. To what extent does the NCQA work incorporate the long-term care services of a person?
LTSS. So in the care coordination piece, and I'm looking at Tricia to make sure that I'm speaking to the standards correctly. My understanding is that there's an expectation that practices will coordinate care across the continuum of healthcare delivery, which includes specialty care, behavioral health, long-term services and supports, community resources, so places like homeless shelters, food banks, I don't think those are specifically written in, but that is the expectation. And so LTSS is certainly a component of that spectrum of care delivery where we expect the practices to coordinate care and ensure that if someone from the nursing home is admitted to the hospital that is one of their patients, they will help facilitate the transition back to the nursing home. That's just one example.
Right. And as Will said, so we have an expectation that the practice will identify what types of community services, sort of outside of the typical traditional medical system of care, are needed by individuals in their practice, and sort of maintain a resource list of those community sources that they kind of keep track of and provide connections to for their patients. I think, interestingly, NCQA has also done additional work outside of our medical home activities on the issue of long-term services and supports and how to evaluate programs and how well they're providing for those services. Our care management expectations are aligned with the kinds of things that we look for in programs that are trying to integrate medical and long-term services and supports. So there's that tie-in, but we'd also be in a position, I don't happen to be the expert on that, so I wouldn't be able to speak to it, but we have a white paper on the subject of long-term services and supports in the care of dually eligible patients, and how we can see better coordination of services across the system over time. And so we have researchers who've been doing a lot of work in that space, and we'd be happy to connect.
Yeah, happy to put the person that
Well, this is great. I don't see any more questions, but that doesn't mean you won't get them later. Thank you very much, both Trish and Will. And as I said, this video will be up online very soon, and the slides will be posted as well. Thank you so much.
All right, thank you.
Take care.
Thanks.